We've been looking at a number of strategies to try to improve the experience for the cancer inpatients, try to streamline their inpatient stay and try to discharge them as safely and effectively as possible. We had a number of challenges and assumptions that we had made about the level of care that inpatients were getting, and it was using these assumptions that made us try to focus the areas we wanted to test. One of the key areas was the admission of patients from the community. We were concerned that a lot of our patients who were due in for chemotherapy, radiotherapy or supportive care were being rolled over, if you like, to the next day or even for several days when there was such a pressure on beds. So we wanted to test what the figures were regarding rollovers and then try to introduce a new system where we could try to admit these patients in a more efficient way. We had a number of assumptions regarding patients who were not in the oncology ward, the so-called outliers. Now, there are a number of different types of patient who could be on an outlying ward but could also be a, inverted commas, cancer patient. Now, obviously many patients with a history of cancer may be admitted for a completely unrelated illness, in which case they would not necessarily truly be an outlier from oncology, but they came into hospital to be under the general physicians or the surgeons. There are clearly other scenarios where they definitely have a new oncological problem and they should be under an oncologist, but they're not able to get onto our ward. And again, it was looking at this range of outliers and try to establish whether they should or should not be moved from which ward they were on. We also had the assumption that we were not doing enough formal ward rounds. Very few of us in our job plans as consultants have the time and space to be able to do these ward rounds. So we wanted to know whether, if we did start doing them, or if there was space in the week to try to introduce some formal assessment by the consultants, whether this again would have an impact on the length of stay and the experience for the patient. I think doctors are key in trying to improve the length of stay for cancer inpatients and improve their patient experience. There are a lot of pressures on doctors' time, whether it is consultant senior staff or the junior doctors in training or the doctors on the ward. However, there are a number of strategies that can be used and we have been testing to try to improve the efficiency of the doctor's time and to have a maximal effect on that patient's inpatient stay. One thing we've been looking at particularly with the pressures of a consultant job plan and the limited time during the week to put in daily ward rounds, we've been looking at a weekly consultant meeting where all the ward staff, the nursing staff and the junior doctors on the ward, along with the middle grade registrars and the senior consultants, are all present to discuss all of the inpatients that are currently in, to discuss the outliers and to also look at the forthcoming admissions for that week. Hopefully, therefore, decisions can be made in advance for particular patients about how we can most safely and efficiently look after their care and plan their discharge. So we've been testing to try to improve the patient's inpatient experience and their length of stay, and we looked at 4 strategies which we thought might have an impact on this. We looked at daily consultant ward rounds, having a consultant presence on the ward to discuss all of the patients in our ward and as outliers every day. This had a big impact on time for the consultants, but it did seem to have an effect on the experience that the patients had, and it did seem to be able to discharge them in a more speedy and efficient way. It may therefore add some persuasion and argument to the need for an acute oncology consultant within each trust to be able to address these sorts of issues on a daily basis within a workable, manageable job plan. Certainly with the current job plans that many of the consultants have, the outpatient commitments are so heavy that it makes it very difficult to find time for daily ward rounds. We also looked at trying to address trigger points for patient discharge. So when a patient was on our ward, we would try to predict, based on the reason for their admission, when we felt that they would need to be discharged. And that may be 48 hours, that may be a 5-patient inpatient stay. But 24 hours before that planned discharge date, we would then have a meeting to discuss whether we thought that they would achieve this, and if not, why not, and how could that be addressed further. We looked at prioritisation of admissions. We looked at trying to give a rank, if you like, to the need for patients to be admitted from the community for either symptom control or active oncological treatment. And the ranking system was based on the aims of any treatment and how many treatments they'd previously had. So, for example, a new patient with an advanced lymphoma, a curable malignancy which requires inpatient treatment with chemotherapy, would have a very high priority to get them in. Patients receiving palliative treatment, although clearly we would like these patients in a very timely fashion, may not come quite so high on the ranking score. We also looked at trying to introduce a weekly ward discussion meeting. So every Monday afternoon in Brighton, we're lucky enough to have all the oncologists from the network in one place, having an academic discussion, consultants meeting, and a variety of other management meetings. We took the opportunity to introduce a ward discussion meeting for half an hour every week, where the nursing staff from the ward, the junior doctors and the senior consultants were all present, and we could discuss the inpatients, discuss the outliers, and discuss the patients who were due to come in that week. And hopefully, and we think it has had an effect on the patient's experience and the timeliness of their discharge. Well, we feel that the testing has had a big impact on our weekly clinical practice. Certainly a number of the strategies that we used in testing has become the norm. The weekly consultant ward discussions, the trigger points for discharge, and the priorities for getting patients in are all now in daily use. We also have some early statistical results to suggest that it has had an impact on the measuring that we've done, and 30% more patients are being admitted on the day that we'd originally planned. We also feel that this has had a knock-on effect at improving the patient experience. Clearly, no one wants to be an inpatient, and if we can improve the timeliness of getting the patients in, but equally getting them out again, then that's undoubtedly in their favour. Most of the consultant oncology colleagues that I work with were very engaged in the project from the beginning. Everyone recognised there were limitations in getting patients into oncology beds, and there were challenges for all of us. I think everyone has been delighted that the testing has had an impact at reducing length of stay and improving efficiency, but I think there's a degree of nervousness and anxiety amongst my consultant colleagues also that because we have so few oncology beds, that it would be showing that we didn't need any more. And I feel that there is undoubtedly an unmet need for a large number of oncological scenarios where we would still want to admit them, and therefore expanding our numbers of beds for our 1.2 million catchment would be appropriate.